Okay, welcome to Cardiovascular Pharmacology 2. We'll go over hypertension agents, then heart failure agents, and thirdly, dyslipidemia agents. So with the hypertension agents, we're first going to go over a little bit about what's normal and what's abnormal. So normal, we expect to see a systolic somewhere below 120, diastolic below 80. And again, hypertension, hyper meaning high, tension is the pressure within the blood vessel, so high pressure within the blood vessel. And what we want to do is we want to clarify or classify what those numbers mean. So if the blood pressure is elevated a little bit, we just say literally it's elevated. Or then we have stage 1 hypertension, stage 2, or if it's really high, we're in hypertensive crisis. So how common or how prevalent is hypertension? In the United States, 85 million Americans have hypertension, and it's associated with many other issues, including heart disease like heart failure, heart attack or myocardial infarction, angina pectoris, kidney disease, and stroke. So that leaves the question, how do we treat hypertension? So what we want to do is look on the left-hand side. You can see elevated versus stage 1 versus stage 2, and we start with non-drug therapy, lifestyle changes throughout. So can the patient lose weight? Can they improve their aerobic activity? Can they change their diet? Can they reduce their sodium intake? Can they moderate alcohol? On the right side, we have drug therapy, which gets more aggressive as we go through, starting with maybe a calcium channel blocker, or thiazide diuretic, or an ACE inhibitor, or ARB. Once we get to stage 2, we start thinking 2 drugs combination from them, and then maybe thinking loop diuretic, potassium sparing diuretic, beta blockers, alpha-1 blocker, alpha-2 agonist. All of these trying to reduce that blood pressure. So we'll start by talking about some of the drugs themselves. The beta receptor antagonists, or the beta blockers, there's 2 different kinds of beta receptor, beta 1 and beta 2. Because you have 1 heart and 2 lungs, that's often a mnemonic to remember, okay, well, beta 1 is with the heart and beta 2 is with the lungs. So when you activate a beta 1 receptor in the heart, you increase heart rate, renin production is likely, and so we're going to get this increase in blood pressure. If you activate beta 2, you're bronchodilating or opening up the smooth muscle. So this is what happens when we activate them. So what happens when we block them? Well, if we were to block beta 1 in the heart, we would actually decrease heart rate. And if we were to block beta 2, then we actually vasoconstrict. So when we see in the next slide about the drugs that also affect beta 2, then we want to be careful with asthmatics. So let's look at these 3 generations. First generation propranolol, which is brand Inderal. It's non-selective for beta 1 and beta 2. That means that while it does lower the heart rate, unfortunately it can in asthmatics cause a bit of bronchoconstriction, and that would be a real concern. Second generation was an improvement on that, where atenolol, metoprolol tartrate, metoprolol succinate are selective for beta 1, so they just reduce the heart rate, and you think, well, that solves it. But it doesn't, because what happens is the body will vasodilate or vasoconstrict, and vasoconstrict to increase blood pressure against this decreased heart rate. So the third generation was supposed to solve that. So something like carvedilol or Coreg is a selective beta 1 blocker and alpha 1 blockage as well. And what we have with this means that not only are we affecting the heart and reducing the heart rate, but we're also taking care of that response or that vasoconstriction that the body would normally do, and hopefully maintaining blood pressure reduction. A common adverse drug reaction for all of them is, of course, bradycardia. We can reduce the heart rate too much, so bradycardic is a heart rate under 60. So the beta blockade is thought to stop renin production in the RAAS system, or the renin-angiotensin-aldosterone system. It creates limited vasodilation. They decrease the heart rate to lower the blood pressure, and again, the body vasoconstricts to keep the blood pressure up. And then the alpha-1 blockage prevents the vasoconstriction to create the best BP outcomes with that third generation. but we still want to be careful. We don't want to use those non-selective beta blockers in COPD or asthmatic patients because of the smooth muscle constriction causing exacerbations. So let's talk a little bit about heart failure and the pathology to start. So cardiac output can't provide enough oxygen needed by the tissues, and something we maybe forget is that the heart pumping and the heart sending blood to the tissues, it's also sending blood to itself. So if the body can't get enough oxygen, it might also not get enough oxygen. So we are going to classify it based on the overall effect of failure. On the left-hand side, we have systolic heart failure or reduced ejection fraction, HFrEF, and the heart cannot pump well enough. On the right-hand side, we have diastolic heart failure. So you've got preserved ejection fraction, and the heart can't fill with enough blood. So a little bit different, but what's going on with systolic is the heart can't pump enough, and then the diastolic is heart can't fill with enough blood. And the systolic is more common, and this is the heart failure we'll talk about in these slides, where the ejection fraction is the percentage of blood left in the ventricle after contraction. So the 5-year mortality rate is 50%, and the most common cause is coronary artery disease, then hypertension. So let's look at the cardiac output factors, where we have the coupling factors, preload, how much blood is left in the left ventricle before contraction, then afterload, what kind of squeeze is required to push blood into the aorta, and then the cardiac factors, myocardial contraction, how powerful that squeeze is, and then heart rate, how fast the squeeze is. So when we talk about endogenous compensatory factors for heart failure, we're talking about an increase in preload, more blood in the ventricle, increase in afterload, the peripheral vascular constricts to keep pressure up, myocardial contraction decreases, and heart rate increases to try to keep blood moving through the tissues. So heart failure medication increases the cardiac output. So let's look at some of the medicines. The RAAS inhibitors, or RAAS. The ACE inhibitors are the first-line treatment for heart failure. They decrease preload and afterload through vasodilation. These include enalapril and lisinopril. ARBs, there's not as much clinical trial data as an ACEI and should be reserved for patients who can't tolerate them. But really, the one caveat is that if you get that ACE inhibitor-induced cough, then we would switch someone to an ARB or a sartan, taking the last letters of losartan, olmesartan, or valsartan. So ACE inhibitors are prils, ARBs are sartans. Another thing with heart failure is getting some of the salt, water, and blood volume off. So furosemide is brand Lasix, spironolactone is aldactone. And what we do is we can decrease venous pressure and preload. It allows the heart to pump more efficiently because we're just taking off some of that fluid that would be going into the heart, and it just couldn't handle as much. So any diuretic can really be used, but loop and aldosterone antagonists are most common. Big drug reaction, that would be the electrolyte imbalance that comes from especially furosemide, which is hypokalemia, or too little potassium, and then spironolactone, too much potassium, and then also with spironolactone we have gynecomastia. In heart failure with the beta blockers, only a few have shown benefit, but it's valuable to kind of think about why would something that slows heart rate be helpful for someone that has a heart that's not doing its job. Well, metoprolol succinate and carvedilol both will reduce heart rate until the decreased heart rate interferes with daily activity. So what we're saying is that you decrease the heart rate a little bit so that the heart can better fill. So if the heart's beating so fast that it can't fill, then it's being inefficient. But if it's so slow that it doesn't get its job done, then it's also not good. So we want to be somewhere in the middle. Adverse drug reactions, of course, with any beta blocker, we worry about bradycardia, and then beta blockers are notorious for causing fatigue. Another drug for heart failure is cardiac glycoside digoxin, or Lanoxin. In the 90s, this was the drug to use, but since it's fallen out of favor. It has electrical and mechanical effects to increase cardiac output, and we'll see those in the next slide, but it has a very narrow therapeutic index, which means that it you go too low, it's not effective, and if you go too high, it's toxic. So we want to be very careful about being between that 0.5 nanograms per milliliter to 0.9 nanograms per milliliter. It's indicated for heart failure and atrial fibrillation, and the adverse drug reactions, dysrhythmias at the very high levels, nausea and vomiting can happen as well. It isn't used first line anymore. It only helps with the symptoms. There's no mortality benefit. Plus, there's a lot of monitoring involved. So, again, I'm going to show you how this works mechanically in just a second. But heart failure and digoxin are not the best friends that they were before. So we begin and we look at the sodium potassium ATPase pump and the sodium calcium exchanger, and what we're really trying to do is get calcium to help with the force of contraction. So we exchange sodium for potassium, then digoxin comes in, have more sodium, and then that sodium exchanges for calcium, and then we see that the muscle cell will work. So this is it in words, but digoxin binds to sodium potassium ATPase, increases the sodium levels. Sodium leaves the cell via the sodium calcium exchange, increasing calcium levels. Calcium is used by the myocardial cell to increase the contraction strength. So how does it work electrically? So it slows down conduction velocity from the SA node to the AV node, and there's more time in between contractions, allowing more time to fill, and the heart rate decreases a bit. So we can see this in the slide where we have heart failure with no digoxin, and this happens very quickly. And then we have it with digoxin. It slows down a little bit, allowing the heart to fill. So once we have medication effects on cardiac output, we decrease preload and with ACEs and ARBs and diuretics, afterloads with the ACEs and ARBs. Myocardial contraction can increase with digoxin, and then heart rate can go down a bit with digoxin and beta blockers to help make the filling more efficient and cardiac output better. So again, preload decreased, less blood fills the heart each time. Afterload decreased, it's easier to pump that blood out of the heart because we're not pushing into as much pressure. The contraction is increased, we get more squeeze to pump the blood, and the heart rate's decreased, more efficient blood pumping. So dyslipidemia is dys meaning bad and then lipid. So we're in some way the lipids are just not working the way that they should. So VLDL, or the levels aren't. So VLDL is a very low density lipoprotein. It's all about transporting triglycerides from the liver to the tissues. LDL is low density lipoprotein. So this is where the liver goes to the tissues. This is the bad cholesterol. And then the HDL is the high density lipoprotein that transports cholesterol from the tissues back to the liver. This is the good cholesterol. So what's the big deal? Well, high triglyceride levels, for example, are associated with coronary artery disease and plaques. The treatment for the lipid disorders, usually it's not dictated by blood levels anymore, but hypertriglyceridemia is an exception, and we begin when the triglycerides are greater than 500 milligrams per deciliter. So one example is fenofibrate, or Tricor. It causes a creation of more lipoprotein lipase, breaks down triglycerides in the liver, so the VLDL levels decrease, less triglycerides for them to transport. So when do we use this? Hypercholesteremia, hypertriglyceridemia, and then mixed dyslipidemia as well. Now we might see some abdominal pain, backache, abnormal liver function tests, but when you think fenofibrate, think triglycerides. But what's it look like when you've got too much cholesterol? Well, you start with a normal artery, but then you get this damage. Maybe it's from smoking, maybe it's hardening of the arteries, and then you get this fatty streak. And then this fibrous cap comes on top, and then the cap ruptures, and we see a thrombus, and that occludes or blocks the area. So again, a normal artery, everything moves smoothly. Number two, excessive lipids accumulate, form a fatty deposit called a fatty streak. The streak is covered by fibrous tissue in the body, and then that cap ruptures and the clot or thrombus forms. And if it breaks off, it can end up in smaller vessels, cause thromboembolisms, and so forth. So how do we treat it? On the left side, we have non-drug therapy. So we decrease fat, fatty acids, cholesterol in the diet, try to get weight loss of 10%, smoking cessation, controlled hypertension. On the right side, we have drug therapy, and the statins are definitely the mainstay. So the HMG-CoA reductase inhibitors. And we dose it based on cardiovascular risk and other disease states rather than saying, okay, your LDL is this or your LDL is that. Two examples are atorvastatin and rosuvastatin, so Lipitor and Crestor. HMG-CoA is the enzyme responsible for creating cholesterol in the hepatocytes, and statins inhibit that HMG-CoA to decrease cholesterol production. So the indications: hypercholesteremia, hypertriglyceridemia, mixed dyslipidemia, and the famous reactions are the muscle pain or the rhabdomyolysis and tendon rupture. So rhabdo is where you kind of dissolve the muscle, and the muscle pain or myopathy will usually precede it, but that's a very serious condition. The maximum LDL lowering in 4 to 6 weeks, but some results in 2. Grapefruit juice and any CYP3A4 inhibitors cause levels of statins to build up, so we want to be careful about that. And then it's dosed in the evening generally, as most cholesterol is made overnight, though atorvastatin is one of those that doesn't necessarily have to follow that rule. And if you were wondering what HMG-CoA stands for, it stands for 3-hydroxy-3-methyl-glutarol coenzyme A. But the most important thing to know is it's involved in it's the enzyme responsible for creating cholesterol in the liver.